Welcome to this, what will be a series of presentations about addressing mental health substance use in the youth justice setting. My name's Garner Clancy. I'm from the Sydney Law School. It's with great pleasure I welcome you to this presentation from staff of the University of Sydney Matilda Centre. You might be aware that the University of Sydney and Youth Justice New South Wales signed a Memorandum of Understanding in July of this year. This is to encourage greater collaboration between the two organisations. And as part of the signing of the MOU and this collaboration, we thought it'd be beneficial to showcase some of the work and capabilities of the University of Sydney. And there's no better group to deliver the first presentation than the Matilda Centre. So I'm very pleased to be joined by three staff members from the Matilda Centre, Emma Barrett, Christina Marel, and Katie Dean. Before I begin, I'd just like to acknowledge the tradition of custodianship and law of the country on which the University of Sydney campuses stand. We pay our respects to those who have cared and continue to care for country. I'm on Gadigal land and acknowledge that fact. Just want to give you a sense of what the session will include this morning and kind of give you a sense of the format. And to just say a few words prior. I'm not going to give lengthy introductions to the speakers. Time is short and we could spend 10 minutes talking about the qualifications and amazing skills of the three researchers who will be presenting aspects of their work. So I'd much prefer you hear from them than me talking about them. So Emma will talk about trauma and substance use among young people in custody and describe existing Matilda programs to address this comorbidity. Christina will talk about comorbidity guidelines and workforce training and describe existing resources for youth justice staff to upskill them in supporting young people with mental health and substance use comorbidity. And Katie will talk about support for staff mental health and the importance of providing support for staff mental health in youth justice settings. I think this is particularly relevant at this current time. I can only imagine the difficulties of working in a custodial environment at the moment with the concerns about COVID and all of the challenges brought by COVID for the young people in the youth justice centres and youth justice settings, as well as the staff who are involved in supporting them. Before I hand over, I just wanted to say that we're in webinar mode, so please use the chat function if you wish to communicate. That will be the best way to ask questions. I will be facilitating this session, which means I'll watch the chat and then there'll be opportunity for a bit of clarification after each of the three presentations, and then there'll be a more general Q&A at the end. I also want to say, feel free to contact us, whether it be any of the speakers or myself, if you have follow-up queries beyond this. And if you would also like other issues to be dealt with in coming seminars. I'll give a plug to the next seminar at the end, but just to kind of foreshadow that we're expecting the Research Centre for Children and Families at the University of Sydney to be the next group to present in late October. So another exciting set of presentations post. I'm going to hand over to Emma now, who will take us through some of her interesting work that looks at trauma and substance use. Thanks, Emma.
Thanks, Garner. Thank you for a lovely introduction. Yes, we're really excited for this opportunity to showcase some of the research that we've got going on at the Matilda Centre that might be relevant to the youth justice setting. So first, I'd like to acknowledge the Dharawal people, the traditional custodians of the land on which I live and work, and pay my respects to their elders past, present and emerging. And I extend that respect to any Aboriginal and Torres Strait Islander peoples meeting today. This first slide, I'd just like to briefly touch on what we do at the Matilda Centre. We aim to provide innovative solutions to address mental health and substance use disorders, which we know are leading global causes of burden and disease in young people. So we aim to bring together globally recognised researchers with a shared commitment to the prevention, early intervention and treatment of these disorders. We aim to lead research to build the evidence base for a thriving and empowered younger generation. And we believe it's really important to engage with decision makers and people with lived experience to enact this change. In terms of relevance for Youth Justice New South Wales, from the Young People in Custody survey, we know that young people in custody are 6 times more likely to have a mental health or substance use disorder. We also know from research in Australia and internationally that there are really clear links between mental health, substance use and offending, and that treatment of these disorders can have secondary impacts on offending. We also envisage that the work that we do at Matilda Centre can directly address some of the recommendations that the Inspector for Custodial Services report had in terms of treatment of young people in custody and also enhancing staff professional practice. So in terms of trauma, the research has highlighted that there are really high rates of trauma and repeated trauma among young people worldwide. We did a study looking at the Australian general population and found that 41% of adults, so approximately 6.5 million people, are exposed to trauma before the age of 17. And these are a wide range of traumas, but more commonly witnessing domestic violence, unexpected death of a loved one, and sexual and physical assault. Multiple or repeated trauma exposure is also common in the Australian general population. When we look to young people or asking young people to self-report rates of trauma, there's not much research in this space here in Australia, but we've conducted a couple of studies, both studies of samples of over 2,000 young people, and we found that half our study of 18-year-olds reported experiencing traumas such as sexual assault, physical assault, car accidents and natural disasters. And in another study, 1/3 of our 13-year-olds report having experienced an adverse childhood event, such as physical or emotional abuse or neglect. When we move to incarcerated populations, we see even higher rates of trauma. And again, the Young People in Custody survey has highlighted that close to half young people in custody in New South Wales have experienced trauma, and 68% report experiencing childhood abuse or neglect. This graph here just highlights the different types of trauma experienced by young people in custody. And as you can see, more commonly witnessing someone being badly injured or killed, followed by physical assault, life-threatening accidents, and other traumas. This is a really important issue, trauma in young people, given that childhood and adolescence is a really vulnerable developmental period that's particularly susceptible to the impacts of trauma. We know there's a whole range of substantial changes going on at this age, and it's an age when we're developing a foundation for a whole range of things, including relationships, self-awareness, sense of independence, and so forth. We also know that traumatic events can have different impacts on different people too, and that there are many factors that can influence how someone responds to a trauma. So this can be in relation to the trauma itself or other individual factors or external factors as well. But what we know for sure is that trauma can shape or redefine a person's views about themselves, about others, and about the world around them. And we know also among people in correctional systems that these kinds of views that people have about themselves, the others, and the world around them can be really enhanced as well. Among those impacted by trauma, there is an increased risk for a whole range of difficulties, and these are manifested by low educational attainment, unemployment and homelessness, high-risk behaviours, aggression and imprisonment, also chronic physical health conditions such as cardiovascular disease, diabetes, cancer, and of course mental health disorders, suicide and substance use as well. Research has shown that the earlier the trauma is experienced in life, the greater the risk there is for these problems. And also among those who are exposed to multiple traumas, there's an increased risk for cumulative impairment in these domains. Post-traumatic stress disorder is the more common disorder that's developed following exposure to trauma. And I've just got some information there on what the Diagnostic and Statistical Manual of Mental Disorders uses in terms of defining post-traumatic stress disorder. And as you can see, there's specific symptom types. So the first being re-experiencing symptoms such as nightmares, flashbacks, physiological reactivity. There's also the avoidance cluster of symptoms. So avoidance of trauma-related memories, thoughts and feelings, avoidance of people, places and activities that remind them of the traumatic event. There's negative alterations in cognition and mood for people who have post-traumatic stress disorder, negative beliefs about themselves, the world, and people as well, I mentioned earlier. And lastly, this last set of symptoms, I think, can be quite an issue for people who are within the correctional system. Alterations in arousal and reactivity, so irritable behaviour, angry outbursts, hypervigilance, reduced concentration. So we're finding in our research that it's these symptoms that can put people at increased risk of perpetrating violent crime. So how common is post-traumatic stress disorder? So we know from research that Tony Butler and colleagues have led among adult prisoners that post-traumatic stress disorder is 10 times more prevalent in the prison setting compared to the general population. In their study, they found that 1/4 of the adults in prison have current post-traumatic stress disorder. And the young people in custody survey revealed that 13.5% of young people have meet full criteria for post-traumatic stress disorder, which is significantly higher than the general population. And this study also highlighted that there are high rates of subsyndromal post-traumatic stress. So people who are presenting with symptoms that don't meet the threshold for diagnosis of PTSD, but they are experiencing re-experiencing symptoms, avoidance and arousal. Interestingly, in young people in custody survey, the prevalence of any PTSD symptoms didn't differ by gender or by Aboriginality, but indeed, researchers are highlighting the fact that there are significant cultural differences in the experiences and expression of trauma and mental health that can place Indigenous Australians at risk of misdiagnosis and ineffective management. So just a point there to highlight that critical gap in research in this space. We know that PTSD and alcohol and other drug use disorders commonly co-occur. So people with post-traumatic stress disorder are significantly likely to have a co-occurring substance use disorder. Studies have found that half of adolescents with PTSD also have a co-occurring substance use disorder. And studies have also found that they're in fact the two most prevalent mental health disorders in the criminal justice system. So why would an individual with PTSD be more likely to have an alcohol or drug use disorder? There's been a few theories put forward, and the more commonly, endorsed theory is the self-medication hypothesis. So the idea that someone would use alcohol or other drugs in order to medicate their PTSD symptoms of re-experiencing or arousal. But regardless of how these disorders develop, once they've both established, they maintain and exacerbate the other, leading to a really chronic course of illness and significant treatment complications. And indeed, we conducted a survey of adolescent service providers in Australia, and they rated that this comorbidity is significantly more difficult to treat compared to PTSD and substance use disorder alone. But they also commented that it's quite it's a highly rewarding opportunity to treat these young people with this comorbidity. And that was around helping young people achieve their goals and making a difference in their life. When we look at this comorbidity as well, we also see not only treatment complications, but a whole range of harms. And my research and others has found that people with both post-traumatic stress disorder and substance use disorder are at increased risk for perpetrating violent crime. In one study, we found they're 4 times more likely to perpetrate violence compared to people without PTSD, just substance use alone. In another study, we linked people's self-report to the Boxer offending records and found that 1/3 of our sample of people with these co-occurring disorders have a history of a violent crime. This is just a summary of some findings from a study conducted in Queensland, which looked at people's experiences of pathways to incarceration. And one of the more common pathways was highlighted to be the experience of child and adolescent trauma, a lack of support for the treatment of trauma, the subsequent substance abuse to mask their pain, and then a brain snap that can occur before perpetrating their violent offence. So what can we do in this space? There's some really exciting research coming out, and over the past decade or so, the studies around the world have shown that the simultaneous treatment of both substance use disorder and PTSD by the same clinician is considered the best approach. And indeed, clients prefer to receive this. We know psychological intervention is recommended treatment for PTSD, and exposure therapy is the gold standard. Traditionally, this form of therapy was considered inappropriate for people with substance use disorder, with the concern that the distressing emotions that are elicited during therapy may be too overwhelming and lead to more substance use or put them at risk of self-harm. But indeed, the research is showing that integrated exposure-based therapies is not only effective, but also safe for this population. So we looked to a treatment. So we evaluated the COPE intervention among adults with co-occurring post-traumatic stress disorder and substance use disorder. And this was led by Kath Mills at the Matilda Centre and others in the US who developed a treatment called concurrent treatment of PTSD and substance use disorders using prolonged exposure. And this treatment manual is now published in the Oxford University Press Treatments That Work series. It's a synthesis of 2 evidence-based interventions. I won't go into too much detail, but there's a lot of information online for those interested. And as I mentioned, we conducted a randomized control trial among adults with this comorbidity and found some really promising results in this space. And that was published in the Journal of the American Medical Association. We also found some really interesting, findings came out of this study as well. And that was the idea of that we really need to intervene earlier in the age in terms of lifespan for this population. So the average age of first trauma in this adult population was 8 years, and the average age of first intoxication was 13 years. And despite experiencing PTSD for an average of 10 years, and some people are up to 30 years or even longer, and undergoing many episodes of substance use treatment, only 1/3 had received any treatment for their PTSD. And so we thought that this is a really critical need to intervene early before these disorders develop into chronic relapsing conditions. And so that inspired us to develop the COPE adolescent treatment. And I did this as part of a Fulbright scholarship as well over in the US, and worked with other experts to adapt that adult treatment for co-occurring post-traumatic stress and substance use disorder for adolescents. And so some of the changes that we made was to include motivational interviewing and an optional caregiver component. And we also modified the language and examples of the treatment as well. So we're currently conducting a randomized control trial funded by NHMRC and Australian Rotary Health among adolescents with this comorbidity. And we're comparing COPE adolescent to supportive counselling. And we are hypothesising that those who are randomised to receive the COPE adolescent treatment will show not only reductions in PTSD, but also in substance use and improvement in behavioural, social, emotional outcomes, including aggression as well. So I've just got that slide there with some information on the therapy itself. So there's 3 broad stages you can see there with some details around the therapy itself. So incorporating the exposure therapy there in stage 2. And then this slide here just presents some of the preliminary findings we have for this study. So as I mentioned, it's ongoing, but we've got 39 young people recruited in the study, and 69% of them are female. 1/3 have a history of arrest. So these are young people we've recruited from the community or from treatment services who are presenting though with quite high rates of arrests, and also experience within the juvenile detention or prison settings as well. And 41% also report a history of homelessness. This graph just depicts the types of traumas that are experienced by this sample, similar to other samples of young people who have got post-traumatic stress, a whole range of traumas that the sample have experienced. On average, 6 years old when they experience their first trauma. Majority of the sample have complex or multiple traumas, and while we didn't have an inclusion criteria, they didn't need a diagnosis of PTSD to be part of the trial. They could have some subsyndromal levels of symptomatology, we still found that 87% have full PTSD. Age 14 of their first use of alcohol, other drugs, with cannabis and alcohol, the more commonly used substances for this sample. And similarly, we had quite a lax criteria for inclusion in the study in terms of substance use. I think it was they just needed to have used past month some alcohol or substance. And they, however, are presenting with quite severe levels of substance use disorder. So in terms of the outcomes from this study, please stay tuned. We're very excited to start looking at some of the outcomes from the treatment itself. But I have been talking to others and do think that this is potentially quite a relevant treatment for the youth justice setting. And indeed, I look forward to talking further about the potential for this treatment or approach for the setting. And when we do go to look at what's been done in this area internationally, what's been great is that there are 3 lovely systematic reviews published this year that quite nicely review all the literature to date, and they've only found out just a handful of studies that have looked at trauma-specific treatments for justice-involved youth. And these studies provide some evidence that CBT, including trauma-focused CBT, is effective in not only reducing PTSD, but also affecting behaviours as well. But importantly, I think these studies can highlight also some significant gaps or opportunities for future research and for collaboration as well. So indeed, they point that we need a lot more high quality RCTs in this area. Interestingly, no studies looked at substance use either as a treatment target or an outcome variable. No studies, to my knowledge, were conducted in Australia. And one of the systematic reviews really highlights the need for more partnerships. And this is a quote from that study: need for more partnerships between academic institutions and juvenile justice agencies. So just 2 more slides to finish up on. It was just, I thought people might be interested in some of the things that we've been thinking about in terms of treatment of these disorders in the correctional setting. So we first were working with adults in the prison setting, and some of the issues we talked about were the fact that these contexts can be settings where alcohol and drugs, or are settings where access to alcohol and drugs is restricted, but also trauma can be triggered. So we might expect an increase not only in substance use withdrawal symptoms, but also trauma symptoms, and indeed post-release as well, when people are returning to situations where there are more opportunities or pressures to use substances, and also times when trauma can be re-triggered. We can also potentially expect an increase in substance use symptoms, risk of overdose, we know also, and trauma symptoms as well. And this slide here just highlights some findings that we had from a trial we did conduct with male prisoners. So these are adult prisoners. We opted to select a treatment called Seeking Safety, which is does not involve exposure therapy, given the contraindication of using that therapy within the prison setting. Seeking Safety is another evidence-based treatment for post-traumatic stress and substance use disorder, but is a present-focused treatment, so focuses on positive coping skills and other CBT techniques, cognitive restructuring and so forth. In this trial, we found some really promising results in terms of treatment outcome. All people who were informed about the study and wanted to participate, and we're really happy with the retention too, given the challenges there are around running these sorts of trials within the correctional setting. We were also very pleased to see the positive feedback from participants in the trial. People wanted more of the programs like this. They wanted longer sessions. They wanted more time spent talking about the trauma. They also had some really interesting suggestions around practicality, so that it might be better for them to do it on parole when they first get out, or just start just before they leave as well. And one of the more interesting findings in this study was we had intended to have a control group. So we had half the sample receive the treatment and half be treatment as usual. And halfway through the program, we realized that some people in the treatment group were sharing their materials with the control group participants, which unfortunately for scientific rigor, it's an issue, but I think what a powerful message that sends, that people are not only wanting to seek treatment for these disorders, but also sharing their information to fellow inmates as well. So just this last slide, I thought it would be good to end on a comment from one of the participants we had in our study. This is an adult male. It is my belief that I'll live with my demons for life. Using experiences such as this, I'll endeavour to make my life better for me and those around me. But until there is a shift in the policy and behaviour of institutions housing inmates with mental health issues, PTSD, along with its insidious mates, will remain prevalent in the prison and the justice health system. Thank you.
Thank you, Emma. That was fantastic. And I think people who work in the system will obviously respond to the focus of yours, the intersection between trauma and mental health and drug and alcohol use. Just a couple of quick questions, perhaps while Chris gets ready to present. One kind of question is really practical. Can people get access to the slides and data and links? So I presume that will be a yes in some form. And the other was just two questions about what are the qualifications of people delivering the treatment and how long is the intervention?
Yes, so the COPE intervention, the COPE adolescent intervention, requires people with, or requires moderate, I think the terminology we're using, moderate clinical skill. And so postgraduate qualifications in psychology, psychiatry and similar. And there's also formal training and it's recommended ongoing supervision for that, given the intensity of the therapy itself. But the Seeking Safety program, however, is much more in terms of broad, in terms of the people that can deliver that. So that's an example of another evidence-based program that might be more broadly applicable.
Great, and how long?
So the adolescent program, the COPE adolescent program is 13 modules and offered up to 16 sessions.
Brilliant. Thank you. I think you've responded to the key questions. Thank you very much for your presentation. I think lots of people will stay tuned as you suggested. And I was particularly pleased to see the recommendation for academic institutions and youth justice agencies to work closer together. I agree. Thank you, Emma. I will now invite Chris to talk about the comorbidity guidelines that she and others have been working on from the Matilda Centre. Thank you, Chris.
Thank you. Hi, everybody. Thank you so much for coming along and inviting me also to present today, Ghana. So I would also just like to start by acknowledging and paying my respects to traditional owners of the lands on which we're meeting, and of course recognize that we are meeting across different areas today. So the traditional owners of the lands that I'm currently on are the Gadigal and Wangal peoples of the Eora Nation, but would also like to pay my respects to other traditional owners of the lands for everybody else who's here. So today I'm going to be talking about comorbidity and a resource that we have developed to build workforce capacity in relation to comorbidity, known as the Comorbidity Guidelines, or more formally known as the Guidelines on Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings. And even though these were developed specifically for alcohol and other drug workforce, I'd be really keen to hear any feedback as to whether you think these might be useful for youth justice. This was developed as part of a broader program of work which is being conducted through the Matilda Centre. And interestingly enough, it just occurred to me as Emma was talking, this was originally led by Kath Mills, who's also being featured in Katie's talk. So I think maybe she should have been invited to talk here, or should be giving all of our talks today. Anyway, before I talk about the guidelines, I just wanted to clarify what I mean when I'm talking about comorbidity. So broadly defined, comorbidity refers to the co-occurrence, either lifetime or current, of two or more disorders. And my focus here is on the co-occurrence of alcohol and other drug, or AOD, and mental health conditions or disorders. There are, of course, a lot of other types of comorbidity, including other AOD use disorders, including tobacco, physical health conditions such as cirrhosis, hepatitis, heart disease, and diabetes, intellectual and learning disabilities, cognitive impairment, and chronic pain. And the co-occurrence of one or more AOD use disorders with one or more mental health conditions is often referred to as dual diagnosis. But this term can be misleading because a lot of clients present with a range of co-occurring conditions of varying severity. The reason we developed the comorbidity guidelines is because mental and substance use disorders are two of Australia's most common and burdensome health conditions. They affect around 1 in 5 Australian adults each year, and they frequently co-occur, as I'm sure you're aware, as you're in contact with populations who have these conditions at high rates. It's estimated that around 1 in 3 Australians with a substance use disorder also has a mental health disorder, but this rate can be as high as around 75% among people who are seeking treatment. There are also many people who experience symptoms of their disorders, but they don't necessarily meet the criteria for a diagnosis of a disorder. And this means that a lot of people can have their lives significantly disrupted by their symptoms of their disorders, but without necessarily meeting diagnostic criteria, they can sometimes fly under the radar of some services. The most common mental disorders that we see to co-occur with substance use disorders are typically the same that we see in the general population, which are anxiety and depression, PTSD and personality disorders, but we also see elevated rates of bipolar disorder, psychosis, ADHD, OCD, and eating disorders. And the fact that these disorders co-occur is problematic because once they're established, each serves to maintain and exacerbate the other, a little bit like Emma was mentioning as well. Not only do people with comorbidity experience symptoms of their mental health and substance use disorders, but they also have quite complex trauma histories, often starting early in childhood, again, like Emma talked about, are in poorer general physical and mental health, have poorer social, occupational, and interpersonal functioning, more severe and extensive drug use histories, and are at increased risk of suicide and self-harm. There also tends to be higher rates of substance use and mental health conditions among some populations in comparison to the general population, for instance, among homeless people. And as Emma mentioned, as I'm sure you don't need to be telling you, rates of AOD use and mental health disorders are also elevated in prison populations. So the most recent mental health of prison entrants in Australia report conducted by AIHW found a third of prison entrants reported having received a formal mental health or substance use diagnosis, which is 2.5 times higher than the general population. 16% were taking medication for their mental health disorder, and 14% were experiencing high levels of psychological distress. So in comparison with other prison entrants, those with poor mental health had more extensive prison histories, poorer education, higher rates of unemployment and substance use. There were also higher rates of risky alcohol, illicit drug use, and smoking than in the general population, particularly among those with higher levels of psychological distress. And of course, these are just some of the different population groups who experience higher rates of substance use and mental health conditions. There are lots of others. And research has shown that people with mental or substance use disorders die an astonishing 20 to 30 years earlier than the general population and spend the last 10 years of life living with disabling chronic illness. And in fact, comorbidity has been identified by the Mental Health Commission as one of health's most significant challenges. In terms of the need for comorbidity guidelines, current approaches to the treatment of these disorders has been not adequate or inadequate. Very few people with these conditions receive effective treatment, in part because they have difficulty accessing services, and also because of a lot of stigma that they're faced with when they do. But also because when a person does manage to access treatment, their care can be fractured and disconnected. The clinical services often adopt a traditionally siloed approach whereby mental and substance use disorders are treated separately, which can limit treatment effectiveness. And as a consequence, people can be bounced between mental health and AOD services with little continuity or coordination of care, and a lot of people end up falling between the cracks. But comorbidity is not an insurmountable barrier to treating people with substance use disorders, and research has shown that people with comorbidity can benefit just as much as those without from usual AOD treatment. So this brings me to the comorbidity guidelines, and they were originally funded in 2007 by the Australian Government Department of Health and Ageing, as it was at the time, as part of the Comorbidity Initiative, and they were led by Professor Catherine Mills. The first edition were published in 2009. They were extremely popular. Almost 16,000 hard and electronic copies were distributed across Australia. But since they were first published, the research relating to the management and treatment has expanded considerably. So we were funded in 2014 by the Australian Government again to update and revise them so they would reflect the most up-to-date evidence. They aim to provide practical evidence-based guidance for AOD workers on the management of mental disorders in alcohol and other drug treatment settings, and specifically to increase AOD workers' knowledge and awareness of mental health conditions, improve the confidence and skills of workers in relation to comorbidity, improve workers' ability to identify mental health conditions, provide guiding principles for working with people with comorbid mental health conditions, provide practical information on the management and treatment, provide information regarding referral processes, and then provide resources that can be used to facilitate all of those things. In terms of what is actually in the guidelines, they're structured in 3 really chunky parts. Part A covers a lot of background information in terms of the prevalence, why comorbidity is important, some guiding principles of working with people with comorbidity, and that really forms the basis of our approach for addressing comorbidity, and also a framework for the classification of disorders according to the DSM-5. And then part B of the guidelines covers responding to comorbidity, and that includes holistic healthcare, identifying comorbidity, risk assessments, care coordination, approaches, managing and treating specific disorders, and worker self-care. And part C covers issues that might be relevant for specific treatment groups. And that's not to say that these groups were not included in the main body of the guidelines, but if we found specific evidence relating to these population groups, we included them here for easy reference. There are lots of appendices which incorporate practical tools for managing people with co-occurring conditions, and they cover a range of areas like CBT and anxiety management techniques, motivational interviewing techniques, screening and assessment tools, listing contact information for useful referrals, and other guidelines and resources. There are also client worksheets. We then received some funding from the Australian Government Department of Health to disseminate and translate the guidelines in ways that would really maximise their reach across multiple levels of workforce development, including those who are undertaking their undergraduate and postgraduate studies, as well as in the ongoing professional development of those who are working in the fields. And we've done that by distributing hard copies, building a website, as well as an online training program. This is a screenshot of our website, and it's essentially an online platform. From here, you can register for our free online training program, access our online version of the guidelines, download a full PDF or build a customized version of the guidelines based on your clinical interests or your training needs, which is one of my favorite parts, access information about our face-to-face or train the trainer program, or access resources, screeners, worksheets, and a new webinar library we've been building this year. This is our online training program page, homepage, and this is where you come after you register and activate your account. This is where all of the training modules can be accessed. So there are 11 content modules. They can be completed in any order. They will unlock after the introductory modules being completed, but you don't need to do the whole program, and you can do it in any order. So if you just wanted to do the module on treatment options or upskill in identifying comorbidity and assessing risks, you could just do those modules, which I think are 8, 5, and 6. But if you finish all of the modules, you receive a completion certificate, which will pop up here to download, and that could be used towards CPD depending on your registration bodies. All of the modules vary in length, but if you were to sit down and do it from front to back, it would be about 10 hours. The training is accessible, meaning that it's completely narrated, but you can toggle audio on and off, and it's quite easy to navigate. There are clearly defined key learning outcomes, and these are all assessed at a quiz at the end of each module. And we've used different multimedia approaches, including animations, videos, and case studies throughout the training as well. Every module ends with a 10-question multiple choice quiz. All questions need to be answered correctly before that will be marked as completed, but there's no limit to the number of quiz attempts that you can take, and incorrect answers refer back to the main website, so you can review that section and then retake the quiz. An evaluation of the online training that we finished recently found that the vast majority of participants reported the program increased their knowledge, confidence, and capacity to respond to comorbidity in their clinical practice, which was really great. And that's really it from me. And once again, the website's comorbidityguidelines.org.au. All those resources are free. You can download a PDF copy or register for our free online training program. And I'd be more than happy to answer any questions you have or hear any feedback as to whether you think that these resources might be useful for youth justice.
And fantastic, Chris. Can I just say, I suppose as almost as a preamble to any questions that might come in, one of the things that I particularly admire about the Matilda Centre, one of the many things, is the focus on research being translated into treatment intervention and a focus on prevention. And so what you've spoken to, I think, really demonstrates the intersection between the research, the gathering of all of the data and relevant information, but then turning it into a multitude of really sophisticated products to help people in the day-to-day work. So, you know, congratulations on what is obviously a huge body of work. I'd encourage people obviously to have a look at the materials that are available and pose any questions that you might have for Chris. None came through as you went. So there are no questions from the floor. I am sort of generally interested, perhaps as Katie prepares, I think there's so much to be learnt from the experience that you've gone through in relation to creating material that achieves such incredible feedback, and just that kind of process of thinking about how you develop materials for a big workforce scattered across the country. That may well be a conversation for another day, but I suppose I'm just interested if you have any take-out messages about that process, because that's a incredibly difficult task to match what people need with what you've delivered them. So kind of a broad comment / question if you wanted to say something, and then we might hand over to Katie.
No, that's a really good question. I think one of the things that has made I think that has made these so well received, and I hope continue to be well received, is that we involved people who were receiving them, AOD workers and other clinicians and healthcare workers along the way. So we had so much consultation in the development, and also asked people how they wanted to receive it, whether they would be interested in online training, and if so, what might it look like? Did they want hard copy? Did they want an app? We didn't do an app. Did they want, what else could we do that would help facilitate the uptake into clinical practice? And I think most of the things we were able to achieve were things that people asked for and said that would be useful. So I think, there's been a real movement and a shift towards an online space, which most of this has captured, but there was people just really wanted to have a hard copy, and we really had to fight to get funding to do that, because they're so expensive, and these are huge, they're really big, they're 450 pages, they're a huge resource, they're really heavy, I think they're 4 kilos. To be able to get, I think we've ended up with, I think it was 10,000 copies printed, was a lot, but people just like having them, being able to flick through them really easily to find them what they need quickly if they've got someone sitting in front of them, was just really critical as well. But being able to do that was essential. We needed that feedback from the field as part of the consultation. So I think that played a massive part in what we were doing.
Thank you. Just a quick question from the chat. For the non-clinical workers, do you see this as a practical resource for identifying potential youth in our work?
Sorry, what was the question again?
For the non-clinical workers online, do you see this as a practical resource for identifying potential youth in our work? The last bit I'm not completely sure of, but maybe if you kind of speak generally about its relevance to non-clinical workers.
Yeah, I think it is obviously been developed for people who are working in the field, but it also is useful, I think, for people who are not. There's so much to it. I feel like I'm flying the flag a little bit, but it's not my intention. Identifying, so I've just seen a chat come up, identifying people with comorbidity. Was that the second part? Okay. Yes, there is a lot in there about, so there's one massive chapter on how you would identify people with comorbidity, like what are the screening tools, what you would look for, the different components, different disorders. So I think that while it is useful for people who are clinicians, it would also be useful for people who are not. And I think it is also being used as a recommended text in TAFE and other vocational institutes as part of their drug and alcohol and mental health studies.
Well done to you. Thank you. Tom said thanks, so you've responded to his questions, so thank you very much.
No problem.
We might hand over to Katie, and then after Katie, open up to some broad Q&A. So if you have questions for Chris or Emma, feel free to pop them in the chat as we go, and we can open them up for a wider conversation. Thanks, Katie.
Thanks, Kana. I'm presenting from the land of the Wongal people of the Eora Nation, and pay my respects to their elders past and present. And it's a pleasure to have the opportunity to present to you all today, particularly with Emma, Chris and Ghana, so thank you. This will be a short presentation from me about the importance of providing support for staff, mental health, and very briefly I'll touch on a project we've recently started working on at the Matilda Centre. So lots of research is often aimed at the clients we work with, but it is also important for continuity of care and effective service provision that we consider the impacts on our frontline personnel. Staff mental health affects not only the individuals, but the organisation as a whole,
For instance, it may add extra pressure on a team when staff are on leave. Turnover of staff also creates costs in recruiting, testing, hiring and training new workers. So DCJ reported 1,200 compensable injuries from 2019 to 2020. 22% of these injuries were psychological, and this accounted for 50% of all claim-related costs. And that's just those compensable injuries. So there are a lot that go unreported. The cost per claim is highest where the mechanism of injury is psychological. This is because it's more difficult for injured workers to recover at work in their usual role. And the rate of injury, not surprising to many of you, is highest among those staffing cohorts involved in custodial operations of young offenders and adult inmates. And just a note on this point, it's not broken down in terms of physical and first psychological injury. And just finally, an interesting stat that some of you may not like to hear, the average worker spends over 1/3 of their weekly waking hours at work, which makes it a key environment to deliver training and interventions. So our project, we're developing a stepped care approach to disrupt the cycle of traumatic stress and substance use in frontline personnel. Stepped care is a staged approach to the delivery of treatment services from the least to the most intensive, matched to a person's needs. It also includes the ability to step up and step down to different levels of care as a person may move along their recovery journey. And as part of this, we're surveying frontline personnel and their loved ones, completing a review of the current research and working with our expert advisory committee, which also includes frontline workers. So what are we finding in terms of past research? The key areas we're looking at include, is stepped care effective to help people manage alcohol and other drug use? And we're finding more evidence for the effectiveness of stepped care in the context that it's matched to a person's needs. We're also finding that stepped care is an efficient way to deliver care resources. Stepped care is designed to only give staff as much care as they need to recover, which can allow organisations to deliver effective care, including more intense care to those who need it, while hopefully keeping costs down. And in terms of what interventions have been used in the workplace to prevent and treat alcohol and other drug use, there's a very wide range of interventions used with a range of results. From the studies we've examined, brief interventions are often effective, and this includes any level of screening for alcohol or other drug use. And the workplace, just a note there, is very interesting intervention context. You have a captive audience in your staff, but you're also battling confidentiality and career harm concerns. And this is especially difficult in workplaces that have zero tolerance alcohol and other drug policies, like corrections. And just to note, these studies we've examined are not all targeted at frontline personnel. And we're going to continue to do a review of research as we examine our survey data and feedback from the expert advisory committee. So key focus of this project is having ongoing input from personnel. We're currently surveying frontline personnel and their loved ones to understand their needs in relation to alcohol and other drugs, mental health, and what are their preferred support and treatment services. This includes conducting one-on-one interviews. We also hope to have an understanding of what the barriers and facilitators are to personnel seeking help for alcohol and other drug use issues. And this is key to our project. For instance, personnel may tell us they really want access to counselling, but still may not use it if it involves going through their employer. So the next steps for our project is to collate the findings from the reviews and reviews of past research and survey data from frontline personnel and family and loved ones. And then in conjunction with our expert advisory committee, develop a stepped care model, which is at stage 2 there, and begin testing in the workplace with frontline workers. So a big thank you to our investigator team, particularly our Chief Investigator, Kath Mills, Project Lead, Ash Morse, and also our expert advisory committee and the frontline personnel involved in that, and those who are completing the surveys. And most importantly, if you like to know more info, I understand this is a very brief introduction to the project, but if you'd like to know more as the project progresses, please do get in touch through Ashley Morse or afterwards with Ghana. And that's it from me, team.
Wonderful, thank you. Great job, Katie. You said brief, you kept to the brief. And no questions at this point, but we'll kind of leave the chat open for the next 9 minutes. So a general question about accessing the slides. We might answer, and I might kind of throw to Chris, who seems to be the expert at these things amongst many.
Not at all. You can access the recording will be made available. If you've registered through Zoom, you'll get an automatic email with a link to access that after this, I think in a few days. So they just look out for that email.
Perfect, thank you. And it's probably an obvious statement, but the Matilda Centre website is full of information. There are also bios for a number of the staff who you can access publications from those staff generally quite easily these days. If you click on the bios, you'll be able to pull up publications. So there's a variety of ways of getting access to information. I'll just have a look at the chat and then direct questions. A question's just come in. Considering that refugee experience has its own specific traumatic profile and that this is laid with adverse childhood experiences, how do you seek to identify this in your work? I might direct that to Emma about kind of refugee experience.
Sure, yeah. I'm should start by saying I'm definitely not an expert in this area, and there are Angela Nickerson is someone that comes to mind at UNSW who's an expert in that space. But in terms of assessing trauma in populations, there's a whole raft of different trauma assessments, and a lot of them are available online. And I know in the comorbidity guidelines appendices too, there's a few. And so going through those and seeing the types of traumas listed in those and whether they're relevant to what you're intending to target would probably be a good first step. Yeah.
Thank you, Emma. Next question looks like it's really for Chris, which is about how do you get a hard copy? The guidelines are long and heavy. You did mention the weight. Can you respond to Michelle's question?
We're actually out of print. I'm sorry, Michelle. We've run out of hard copies, but you can still get a PDF online. And I will also mention, I didn't put this in the presentation, but we are at the moment in the process of revising and conducting a review of the evidence for the 3rd edition, which we're hoping will be out maybe next year. We're just going to see how long it takes at the moment. But at the moment, the 2nd edition is the current edition. But stay tuned for that.
What's to stay tuned for? Matilda Centre is producing a mountain of material and information. So I do encourage you to connect with Matilda Centre, join to get any kind of updates and emails. Obviously, social media, I'm hopeless at it, but I think Matilda Centre is quite active. So there's a good way to follow the activities of the Matilda Centre. I'm conscious we've got a few more minutes, so we're happy to kind of stay on and answer any questions. We're equally happy to take any guidance about future events. If you would like to drop that in chat or to email any of us, we're easily found. We work at a public institution, so you can track us down quite easily. There's another question that's come through for Chris regarding the tools on the Comorbidity website. I might let you just read that, Chris, and respond, because there's a few acronyms that you'll deal with better than I.
Yeah, so this is a question about whether it would be useful for caseworkers to use the K10, the DAS21, the IRIS, if they have concerns about young people. I think that's a really great question, and I think that would be a good idea. And maybe Emma, if you wanted to make a comment as that, because you have clinical training, so maybe you could talk about the appropriateness of these in different settings. But I think the reason why we included those specifically was because they could be used for people without being a clin psych. So yes, I would suggest that you have a look at those, but also have a look at, they are in the back of the guidelines, but also they're written in the body, just a little bit of information about them. So just have a look at those and how they're used and things like that. Did you want to say anything else, Emma?
No, I think you've addressed that perfectly. You can see a question there coming through in terms of the COPE adolescent study. So yes, so the 69% female, so that just happened to be the people, the numbers of people who are coming into the study. Yes, so we hadn't randomized in terms of gender for that. So sorry, we are randomizing to the groups in terms of gender, so there'll be equal amounts across those who receive the treatment versus those in the control group. But yes, there tends to be more, I think, higher rates of PTSD too in female, in the general population among females. So that might be reflective of that as well, as to why we have a higher number of females in the sample so far.
Okay, we have a couple of minutes before we will close the webinar, so opportunities for final questions. While that we watch the chat, I'll just say a big thanks to Emma, Chris and Katie for their time today and the preparation for delivering presentations, but a bigger thanks for the work. I think what you and the Matilda Centre are doing is phenomenal because of that focus on research driving treatment intervention and thinking about prevention. So thank you for that. Q&A, was that the one about brain snap? Sorry, yes. So I've had a brain snap. There was an earlier question asking Emma, just to clarify, there was reference in your presentation to brain snap prior to violent incident or episode. And a request for that just to be clarified.
Sure. What I can do, if that person, wants to get in touch with me, I can send them that study actually. So that would, the study itself that's been published by the researchers in Queensland would do a better job at explaining that. But when talking to individuals with this comorbidity and talking to them about their aggression and violence, they do describe a moment of impulsivity or reactivity. So there's no thinking going on, or more often than not, it's that reactive violence or reactive aggression that can occur at the point in which they're perpetrating the crime.
Wonderful, thank you. So I'll conclude heaping praise on you, but say thank you all for being the first in what I hope will be a run of events. I do want to just say on the back of this that what we're hoping to do is have University of Sydney research centres and staff make a few presentations. So next month we're hoping, and I'm pretty confident, that the Research Centre for Children and Families will talk about some of their work, particularly in doing rapid reviews around youth mentoring and some of their research that they're undertaking in the out-of-home care system, child protection system, which obviously connects with many of the kids in the youth justice system. But I also want to kind of say that this is meant to be a two-way dialogue. What I'm really hopeful for is that next year that we have presentations from staff from Youth Justice and related agencies, because what we need to hear is what your day-to-day looks like. I think as researchers and people in university environment, it's often easy to miss some of the nuance, miss some of the complexity. And so I see this very much as a two-way dialogue, not us just kind of dispensing wisdom, but hearing wisdom. So we'll hopefully be working on a bit of a program for next year. So please do contact us, drop me an email, send any of us an email if you've got follow-up questions or suggestions for other events. We're right on 12 o'clock. I like to be punctual. Thank you all for joining us, and thank you again to the presenters. Have a safe afternoon and a great long weekend. Thank you.